Hello everyone, welcome to another session on lipid metabolism. So, today we are going to discuss about disorders associated with lipoprotein metabolism, and we will also look at atherosclerosis. So, coming to disorders, either we can have hyperlipoproteinemias, that is increase in lipoprotein levels, or we can look at hypolipoproteinemias, decrease in the lipoprotein levels. In hyperlipoproteinemias, it can be elevation of a specific lipoprotein in plasma. For this, causes can be primary, that is there is a genetic disorder, or it can be a part of a distinct syndrome, or it can be secondary due to other conditions like diabetes or thyroid disorders or liver disorders. Then most of the times it can be multifactorial, that is there is a genetic predisposition along with some underlying disease, and most often we see that there is a sedentary lifestyle and bad eating habits also which go hand in hand. So, all these put together will lead to hyperlipoproteinemias. So, we also use the word hyperlipidemias, elevation of triacylglycerol and cholesterol. So, dyslipidemia is abnormal levels of either LDL or HDL. What are the manifestations? Again, disclaimer, these pictures that you see are in extreme cases. You would not see these in every person who has hyperlipoproteinemia. So, it can be in the form of xanthomas. These are the most common. So, these xanthomas can be tuberoeruptive, that is painless yellowish papules, or it can be tuberous. It can also be palmar or planar or palmar, and it can also be tendinous. Now, coming to the classification. So, we are still referring to the classification given by Fredrickson in 1967. Okay. So, this classification is based on levels of cholesterol, levels of triacylglycerol, then the chylomicron, VLDL, HDL, LDL after a 12-hour or a 14-hour fast, and what is the appearance of plasma after 24 hours. From a clinical or a therapeutic point of view, we will classify it as hypertriglyceridemias, that is type 1, 4 and 5. We will look at what are these types. So, type 1, 4 and 5 are hypertriglyceridemias. Then we have hypercholesterolemias, type 2A. Then we have combined, both triglycerides are increased as well as cholesterol is increased, that is type 2B and type 3. Okay, so let us look at hyperlipoproteinemias. Type 1, this is hyperchylomicronemia. So, there is increase in chylomicron levels, and the deficiency here is a lipoprotein lipase deficiency, or there can be a lack of ApoC2, which is required for the activation of lipoprotein lipase. So, if we look at the plasma, normally after 2 hours after food, chylomicron levels will decrease. So, the plasma is no longer milky for after 2 hours. But here after 24 hours also you see a creamy layer. So, this tells you it is hyperchylomicronemia. Cholesterol levels will be normal, whereas triacylglycerol levels can be more, will be very much elevated, more than 2000 also. These people are not at a higher risk for coronary artery disease because cholesterol levels are not increased. Restriction of fat intake is important, and even supplement of medium chain fatty acids, so that chylomicron requirement will be less. Type 2A is more a LDL receptor defect, or that is the increase in ApoB, because the receptors are not recognizing the ApoB and the uptake by the cells is not happening. So, LDL levels will be increased. So, there is hypercholesterolemia. Cholesterol levels will be increased and triglyceride levels will be normal. So, these people are at a higher risk for premature coronary artery disease. So, you need to advise restriction of saturated fat, low cholesterol diet and recommended intake of statins. Type 2B is secondary causes due to obesity or bad dietary habits, or due to other disorders like diabetes, hypothyroidism, nephrotic syndrome. So, there is increase in ApoB. Both cholesterol and triglycerides are increased, but cholesterol is increased more than triglyceride. And because cholesterol levels are increased, they are at the risk is similar to type 2A, treatment is also similar. Apart from that, we also need to treat the underlying disorder. So, if diabetes is in control, cholesterol levels also will be reduced. So, same way with hypothyroidism, treat them with by giving thyroid hormone. Next is type 3, dys-beta lipoproteinemia, and here there is a genetic variant of ApoE. ApoE is for uptake of remnant chylomicrons. So, these will not get absorbed. ApoE are not going to be taken up by liver or other tissues. So, there will be excessive ideal and chylomicron remnant. So, increase in cholesterol levels. Because there is increase in cholesterol, again they are at a higher risk for coronary artery disease and atherosclerosis. So, reduction in cholesterol, increase intake of PUFA and drugs like statin. Type 4 is due to a intolerance, that is glucose intolerance or insensitivity to insulin. So, there will be hyperinsulinemia. This is leading to increase in triacylglycerol levels more than the cholesterol levels. So, endogenous hypertriglyceridemia. Cholesterol levels also will be mildly increased. So, they are also at a risk of cardiovascular disorders, and for this they need to look at reduction of body weight, because this will help in keeping increasing insulin sensitivity. Restrict carbohydrates, because overfeeding of carbohydrates also can lead to synthesis of cholesterol as well as excessive triacylglycerols. So, you have to restrict carbohydrate and cholesterol in diet. Type 5, it is a combined hyperlipidemia, exact cause is not known. So, it is more of a triglyceridemia. High intake of PUFA and hypolipidemic drugs will be advised. Other hyperlipoproteinemias, if there is LCAT deficiency, lecithin cholesterol acyltransferase. So, this enzyme is present in HDL and is required for reverse transport of cholesterol. So, if this is decreased, the reverse transport is affected. So, there will be increased cholesterol levels, leads to atherosclerosis. CETP deficiency also, this is for transfer of cholesterol from HDL to other VLDL, IDL or LDL fractions. So, there will be increase in cholesterol levels. Excess of lipoprotein A, lipoprotein A resembles plasminogen and leads to inhibits breakdown of fibrin, interferes with activation of plasminogen and can lead to premature coronary artery disease. Woolman's disease, deficiency of cholesterol ester hydrolase. So, whatever remnants have been taken or LDL has been taken up by the cell is now the vesicles fuse with the lysosomes, and the lysosomes should contain enzymes to break down these. So, if cholesterol ester hydrolase is not present, then it is not converted to free cholesterol and ester and fatty acids. Secondary hyperlipidemias can be increased in diabetes mellitus, both cholesterol and triacylglycerols. In nephrotic syndrome, there is loss of albumin. So, to make up for this loss of albumin, other proteins, other globulins will be increased, which also includes lipoproteins, and there is decreased catabolism. So, that is why there will be increased cholesterol and triacylglycerol. In hypothyroidism, the LDL receptors are decreased. So, LDL uptake is not happening, and therefore, cholesterol reverse transport of cholesterol gets affected. In obstructive jaundice, cholesterol excretion itself is getting affected, so it will increase in blood. Alcoholism, we have looked at it how can lead to increase in triacylglycerols. Coming to hypolipoproteinemias, A beta is complete absence of the beta fraction. So, VLDL, LDL are almost absent or decreased to a large extent. Possible cause could be because of liver and intestinal cells unable to incorporate apolipoprotein B into the lipoprotein. So, excretion will get affected. So, there will be reduced cholesterol triacylglycerol, can lead to they will also manifest with severe fat malabsorption, decreased absorption of fat soluble vitamins, and leads to accumulation of triacylglycerols in intestine as well as liver. Hypobeta lipoproteinemia, similar to the previous one, it is just that there is more decrease, not complete absence. Many mutations have been seen with respect to ApoB gene. So, therefore, synthesis of lipoprotein with reduced ApoB. Hypoalpha, this is decrease in HDL because HDL is the alpha lipoprotein. So, decrease in HDL levels leads to reduced reverse transport of cholesterol. So, therefore, cholesterol will accumulate and they are at a higher risk for coronary artery disease. So, we will that is about lipoproteinemia. So, we will look at atherosclerosis and how do we prevent atherosclerosis. So, in Greek, ather means gruel and scleros is generally referring to anything which is hard. So, this is building up of a waxy gruel like hard substance in the blood vessels. Aorta, coronary artery, cerebral artery are the most commonly associated vessels. It can also affect peripheral arteries. So, if we look at it, we have three layers in the artery, that is the intima, media and the adventitia. We have three layers in normal arteries, intima, media and adventitia. So, now there is lipid accumulation happening in the intimal layer, lipid accumulation. So, you can see that the lumen is big and open here, whereas the lumen size has reduced in atherosclerosis. So, usually for cholesterol uptake by any cell, there should be receptors present on the cell surface and this takes up cholesterol. So, once there is enough cholesterol in the cell, there is inhibition of these receptors and the receptors do not come to the cell surface, so that more cholesterol is not taken up by the cell. Whereas in these vessel walls, arterial walls, the down regulation of receptors is not happening. So, there is a non-specific infiltration of LDL through the arterial walls into the cells. Once the LDL enters into the vessel wall, it will undergo further secondary changes. It can be acetylation or oxidation. So, this is called as modified LDL, and this modified LDL is going to be taken up by macrophages. Okay. So, normally LDL will enter into the cell in the vessel wall, into the intimal layer, and then undergoes modifications to become modified LDL. These modified LDL is a pro-inflammatory substance, that is, it increases inflammation. So, if we are looking at stages of atherosclerosis, stage 1 is formation of foam cells. The oxidized LDL particles are getting deposited in the walls. Stage 2 is progression of atherosclerosis. So, this modified LDL is pro-inflammatory. So, it stimulates many molecules. Monocyte chemoattractant protein is one, which leads to infiltration of macrophages into the vessel wall, and these macrophages in turn will combine with LDL to form foam cells. Macrophages will take up LDL and it forms foam cells, and this gets deposited. Stage 3 is a fibrous proliferation. So, because of this being anti-inflammatory and various adhesion molecules are being generated, this leads to increase in fibrous tissue, that is inflammation and fibrosis. So, there is proliferation of cells, and this is what is going to form the plaque. In stage 4, there is narrowing of the vessel wall. So, here we can see that progressive narrowing of vessel wall will be happening. So, whenever there is narrowing of vessel wall, the fluid that is passing through it, that is blood, there will be lot of turbulence and the movement is reduced because it is moving through a smaller space than it was before. So, there is reduced movement, which in turn can lead to activation of clot formation, or sometimes the plaque that is present can undergo secondary changes like ulceration, calcification. So, when there is an ulceration of the plaque, this causes sticky patches to form, which in turn leads to this in turn leads to formation of a thrombus, and once this thrombus is released, it can go and block other smaller vessels. So, HDL is anti-atherogenic because it promotes efflux of cholesterol, prevents modified LDL from forming, as well as it leads to efflux of cholesterol from the cell. So, what are the risk factors for coronary artery disease? So, we have modifiable factors and non-modifiable factors. Modifiable factors are under our control to a certain extent. So, we can modify, whereas non-modifiable factors are not under our control and cannot be modified. So, controllable stoppage of cigarette smoking. Cigarette smoking leads to oxidative stress and oxidative damage. So, stoppage of cigarette smoking, and controllable factor is decreasing LDL levels, or keeping in check diabetes, or people who are leading a more sedentary lifestyle should adopt more physical exercises, combating obesity, reducing inflammation, iron overload, Even stress, anger are also important factors which are important risk factors for coronary artery disease. Now, non-modifiable risk factors will be gender. You cannot change the gender, and we know that males are at a higher risk for coronary artery disease compared to females, whereas this difference will be negated post menopause. So, till menopause estrogen effect is present and females have a lower risk for coronary artery disease. As age increases, some amount of atherosclerosis will happen. So, if we check, majority of the population, older population will have some amount of atherosclerosis. Then family history is very important, whether parents have had a history of coronary artery disease or siblings have had coronary artery disease, then you are again at a higher risk for coronary artery disease. So, how do we prevent? Reduce dietary cholesterol intake, avoid high cholesterol diets. Again, if you remember, cholesterol is mainly obtained from animal sources. So, milk products, meat, egg and shrimps are high in cholesterol. Vegetable oils and polyunsaturated fatty acids. So, for reverse transport of cholesterol, we have seen previously that polyunsaturated fatty acid is essential, because this is the whatever cholesterol is going to get esterified, it will be with polyunsaturated fatty acid. But you should also remember that there is a omega 6 is to omega 3 ratio that needs to be maintained at 3 is to 1. So, omega 6 is high in sunflower oil, omega 3 is higher in fish oil and coconut oil. Then moderation in fat intake. Fat should not exceed more than 20% of the calorie intake. We should increase amount of green leafy vegetables and fruits, because these green leafy vegetables have a high fiber content which traps the cholesterol and decreases the absorption of cholesterol. They also increase the motility of bowels and help in decrease the reabsorption of bile salts, so help in its excretion. Avoid excessive use of or excessive consumption of table sugar, because we have seen previously also, any excessive carbohydrates that are taken in will be channeled in towards formation synthesis of triacylglycerol and cholesterol. Lead a healthy lifestyle, avoid smoking and moderate alcohol intake. Increase physical activity. So, how do we know what is the cholesterol level, or how much is HDL, how much is LDL? So, there is a blood test that we commonly do, which a panel of tests together called as lipid profile. So, we check total cholesterol levels, HDL levels, LDL levels and triacylglycerol levels. So, the normal reference interval for all these is given by the National Cholesterol Education Program Adult Treatment Panel 3 ATP 3 NCEP ATP 3 guidelines give us the normal reference intervals. We are all following these guidelines. Again, how often should we check for lipid profile? Above 25 years, better to check at least once a year, and if it is normal, then the frequency can be less. If it is abnormal, better to check it more frequently. If there is a family history of cardiovascular disorders, then better to check once in 6 months. Diabetics, those with nephrotic syndrome, renal diseases, thyroid disorders, liver disorders, all of them should check once in 6 months. And if you are suspecting any cardiovascular disorders, then do not wait for any time, get one lipid profile done immediately. So, what are the normal reference ranges? So, cholesterol should be less than 200 milligram per deciliter, LDL less than 130, HDL between 40 to 60 milligram per deciliter, and triglycerides should be less than 150 milligram per deciliter. These are important reference ranges which you should be knowing. Apart from these, there is an extended lipid profile panel also. We can check ApoA levels and ApoB levels. ApoB levels will give us an indication of chylomicrons and VLDL. ApoA levels will give us an indication of HDL. Then the lipoprotein A, high sensitive CRP. We will come to what this is. Homocysteine, I think you must have studied what is homocysteine when you did amino acid metabolism. So, we will look at all these. So, homocysteine is produced during methionine metabolism, that is conversion of S-adenosyl methionine after S-adenosyl methionine is considered the donor for the methyl group. So, once this methyl group is donated to other acceptors, then SAM is converted to S-adenosyl homocysteine, which then forms homocysteine, and then it has to undergo further methylation to form reform methionine. So, this homocysteine has been shown to be a has been shown to increase atherosclerosis. So, if your homocysteine levels are increased, 5 to 15 micromoles per liter is normal. So, if it is more than that, then it can lead to atherosclerosis. Now, high sensitive CRP, HS CRP, this is an indicator of any inflammation. So, if values are increased, then they are at a higher risk for coronary artery disease. Again, this is not highly specific, because any other inflammation, it can be due to some other infection in the body or even arthritis in the body. So, whenever there is any inflammation, CRP can be increased. So, you need to rule out all other causes before asking for CRP. Avoid a sedentary lifestyle, reduce obesity. So, moderation in dietary fat and cholesterol intake. So, reduce the amount of fat and cholesterol intake, take more of vegetable oils and PUFA, green leafy vegetables. We will look at each of these. Normally, vegetable oils and fish oils contain polyunsaturated fatty acids. So, this is required for reverse transport of cholesterol. Omega 3 fatty acids will reduce LDL and decrease the risk of cholesterol, coronary artery disease. So, recommended intake of omega 3 fatty acid is 1 gram per day. And studies have shown that DHA and EPA levels will lower triglycerides. It will also slow the buildup of atherosclerotic plaques and decrease the risk of heart attack. PUFA will reduce cholesterol, but very high intake of omega 6 oil has also been shown to increase triglyceride levels, lower HDL and promote platelet aggregation. And sunflower, vegetable oils like sunflower oil are very high in omega 6 variety. So, normally we need to maintain a ratio in the diet, optimal ratio 3 or 4:1. So, we need 3 or 4 times of omega 6:1 omega 3. Whereas, in an average Indian diet, our ratio is skewed and it is usually around 30:1. And if we look at sunflower oil, in sunflower oil the ratio is about 160:1. So, therefore, it makes no sense to increase your intake of sunflower oil, because it is going to affect this ratio. So, we have to incorporate other oils which have more of omega 3 to bring down this ratio. So, using coconut oil, rice bran oil, or cod liver oil, all these will have more omega 3 and will help to bring down this ratio. Now, coming to trans fat, it is better to avoid trans fats. These trans fats are formed during hydrogenation process. Now, of late all these hydrogenated oils, example the palm oil, all these have been are being regulated and the usage has decreased. Previously, these hydrogenated oils were used because they increase the shelf life of the food that has been processed using these palm oils. However, this is more atherogenic than saturated fatty acid. So, that is why we should reduce trans fatty acid intake. Now, all food manufacturers have to put on their labels how much of trans fat is present. All these chips, pies, in the bakery industry as well as in the frying items where frying is required, all these are the ones which generally used to contain more trans fatty acids. So, it is very important to look at labels before buying and eating these packets. Increasing fiber levels will help to absorb the cholesterol, will help to prevent absorption, that is, it traps cholesterol and then it gets excreted. So, in those who already have cardiovascular disorders or in patients with diabetes mellitus and or where the cholesterol level is more than 220 or there is a family history, in all these people only lifestyle alterations, that is exercise and diet, may not be enough to reduce the cholesterol levels. So, this is where we need drugs or hypolipidemic agents to reduce their cholesterol levels. So, we have various plant derived fibers or legumes. Even onion and garlic will reduce serum cholesterol and triglyceride levels. Then these gugolipids, these are marketed as medicines also. These will help our hypolipidemic and cardioprotective. Now, we have looked at these statins, HMG-CoA reductase inhibitors. We have bile acid binding resins, so that there is no reabsorption of bile acids and they get excreted, so that more cholesterol is excreted. Probucol will increase LDL catabolism. Now, we have a new range of drugs called PCSK9 inhibitors. So, these also have been shown to lower LDL levels. I am sure you are going to be studying more about these and their method of action when you go to pharmacology. Apart from these, these patients will also be started on aspirin to prevent thrombus formation, and vitamin E will be given for combating any oxidative stress, so that it decreases the oxidation of LDL. So, with that we finish the session on lipoprotein disorders and atherosclerosis. Thank you.